Good afternoon, everyone. I want to thank you all for joining us this afternoon, and we hope you'll be able to learn something useful from this talk. It's slightly close to 2 years now, 2 weeks from the date when COVID was first announced in the country, and almost a week to a year from when the COVID vaccines first checked in. And since then, there's been a lot of ups and downs. And you've all been a part of that big fight that the world has been having. And I want to thank all of you for participating in it. So in November last year, we had the Omicron variant that was announced, said to have started in South Africa. And since then, that's what we've been dealing with. It has appeared to be milder, but that's why we're here today, to find out if really it has been milder, whether the vaccines have contributed or anything of the sort. So I want to thank you very much for joining us, and I hope this will be a wonderful session for you all. Today's presenter is Dr. Paul Yonga. Dr. Paul Yonga is an infectious disease and travel medicine specialist. He's also a notable researcher who initiated the Photromid Clinic in Eldoret. He also has done notable work, research work with the International Society of Travel and the HIV/AIDS Society. So if there's anyone to really help us tackle this issue of vaccine and Omicron, I don't think we could find a better person. So thank you very much for joining us, Dr. Yonga, and karibu sana.
Thank you very much, Leon, for that kind introduction. I'm very happy and privileged to Kenya Medical Association for having invited me to speak on this very important topic. I think one of the big questions that patients have asked me, as well as colleagues, is after Omicron has come in, really has the vaccines played a role in dampening the severity of Omicron, or we are just having some form of wishful thinking? And I hope by my presentation, we should be able to clarify a few of those questions. So if I could just share my slides. I hope you can see my slides.
Yes, Dr.
Thank you. Okay, thanks a lot. So, so those are my disclosures. Currently, I'm a principal investigator for the Sanofi Pasteur vaccine in Kenya with a number of other colleagues, as well as a principal investigator on Wellcome Trust, a grant trying to look at potential COVID-19 prophylactic therapies, but I will not comment on any of their behalfs or mention anything regarding the products that we are testing with these organizations. So this will be my outline. We'll just do a brief introduction, look at the evolution of the virus over time, and then look at the vaccine impact against this current variant that we're dealing with, and then conclude with a few remarks. So when you look at the introduction, I'll just probably want to highlight two very key definitions. One we'll start with is what we call the variant of interest, that is VOI. And this really regards to variants that have changes in the genetic makeup that are predicted or known to affect the virus characteristics. And this, we are looking at issues of disease severity. We're looking at how transmissible is the variant, how effective it is in evading the immune system, or how difficult it is to treat in terms of therapy or in terms of diagnostics. And also you look at issues of how the variant has been identified in causing community transmission or clusters in multiple countries. And so you'll find that for the previous 3 or 4 variants of concern that we have, that is Alpha, Beta, and Delta, they actually initially were categorized as variants of interest. But over time, and you look at Omicron, Omicron bypassed the definition of being a variant of interest and immediately was categorized as a variant of concern. And this was done in very quick succession, because when it was sequenced in South Africa, initially it would have been initially first to find it was sequenced. It was sequenced, and then 2 days later, it was made a variant of concern. And so variants of concern initially, first of all, meet the definition of a variant of interest. But in addition, there's an increase in the transmissibility that may lead to a drastic or detrimental change in the COVID-19 epidemiology. And there'll also be an increase in virulence. And that is what now Alpha, Beta, Delta, and currently the Omicron variant have met in terms of definitions. So scientifically, it's known as the B111529, which is designated as a variant of concern, as we've mentioned. And why it is mentioned as a variant of concern is because it was noted to have, from when you look at the wild type virus, that is the Wuhan, what they call the Wuhan virus, you'll find that there are 30 mutations, more than 30 mutations that were on the receptor binding domain. And that one I'll come to in my next slide, of which 15 mutations were of marked significance. And this significance is in that it had the potential of evading the immune system. It also had the potential of evading or reducing the efficacy of the vaccines that we currently have. And of course, at the same time, it also had problems in terms of diagnostics. But in total, when you look at the spike protein, they're a total of 60 mutations leading to a vaccine and neutralizing antibody resistance. And so this is the structure that I'm talking about. So what you look at is actually the spike protein. And my interest would be, if you look at my pointer, is where I am actually pointing, where you see the S1, because S1 is actually the component of the spike protein where a lot of our diagnostics and therapies and vaccines are developed from. And what you can see in the middle, what I'm talking about here is the receptor binding domain. So it is in this receptor binding domain, this is what the virus actually uses to attach to either the alveolar cell or to the ACE2 receptor, which could either be on the lungs, in the alveolar cells, or in the blood vessels. And so this one actually has quite a number of amino acids. So when you look at the wild type virus, as well as Alpha, Beta, and Delta, the number of mutations that you could find in between were not as significant to cause a significant shift in the change of the domain. But with this, as you look down, this is now the actual receptor binding domain of the Omicron variant. And you can actually see just this segment alone, in the receptor binding domain alone, you have over 30 mutations, 50 of which are completely altering the structure of the spike protein. And because of this, you'll actually find that a lot of the therapies, especially the monoclonal antibodies that are being used in many parts of the world, developed parts of the world, to treat mild to moderate COVID-19, as well as some of the vaccines that are in development. To be more specific, the viral vector vaccines, you find that are rendered completely or less effective against this receptor binding domain of the Omicron variant. And this knowledge, I think we need to carry it forward, because we will be using this receptor binding domain knowledge a lot as we go through these next steps of the presentation. So when you look at the evolution, you will actually find that in the late 2020s, when the virus was detected, so I'll try and explain what these colors mean. So we're using my pointer. This sort of red or pink dot is actually what we call the original variant. That is what they call the Wuhan variant. And then you'll find that there were very many other coronavirus variants, but they were not really very significant, but they are considered to have been possible close ancestors of the Omicron variant. But you can actually see there were not as many, because we find that the number of mutations were quite low. They were just probably anywhere between 1 to 5 mutations on your S1 component of the spike protein. And by S1, I mean the receptor binding domain. Then as we move along up to just about early 2021, you'll now see the Alpha variant, the variant that was actually detected in the United Kingdom. And so that had just somewhere anywhere between 6 to 8 mutations. And then slowly the Beta variant that was initially also again sequenced in South Africa also started building up with some anywhere close to between 8 to 9 mutations. Then as we move into mid-2021 towards the late 2021, then the Delta variant started emerging. And this one was noted to have anywhere between 9 to 17 mutations. And then as we move along, because as you can actually see from this phylogenetic analysis, you'll find that we still have quite a bit of Delta variant still circulating. So it has not really been wiped out of circulation. But of course, now the most significant, as you look up, is actually the Omicron variant. And what you will realize is that Omicron variant, there are two phylogenetic makeups of the Omicron variant. We have the BA1 and the BA2. But in terms of circulation, BA1 seems to be the most circulating. And you'll find that it has anywhere all the way up to 30 mutations, but of which 15 are significant. And then a bit of BA2 that has been sequenced in the United Kingdom with a bit of circulation in Europe. So what we still do not know is, like right now, you do know there's an outbreak ongoing in Hong Kong. We do not know which variant or which phylogenetic type of the Omicron variant is causing the problems that we're seeing in Hong Kong. Because as you can actually see, there's quite a bit of hospitalization going on in Hong Kong, coupled by the Omicron variant. And so that alone tells you that Omicron is not as mild as some of us are tempted to think. And you can see how the takeover took off very quickly. So in November of 2021, the curve that I'm currently pointing is what was detected in Africa. So you can find that the genetic sequence really picked up in Africa just right from late November all the way into the early parts of this year. But one of the things that could be driving this is because, number one, Africa, especially South Africa, has one of the most elaborate genomic sequencing facilities globally, as compared to the second, which is now the United Kingdom. And you can see Europe quickly took shape towards the start of December. And you can actually see that also the genomic sequencing also takes place in a very similar sequence as to what you see in the African continent, and to be more specific, South Africa. Then the Asias catch up quite closely later. And so because of this, you do know that all this, the Omicron variant was initially sequenced in South Africa. I'm deliberately using the term sequenced in South Africa because I think there's been a lot of bad press saying that it originated in South Africa, but I think it has to be clear that it was actually sequenced in South Africa. And so one of the things that were noted was that there was an increased risk of reinfection with the SARS-CoV-2 virus due to the emergence of the Omicron variant. And this one I can quickly show in these curves. So what you'll notice is that so far South Africa has had three major waves of SARS-CoV-2, and the one that I'm pointing, which is being in purple, is when the Delta variant was actually causing chaos in South Africa. And now what you can actually, and why I'm pointing this out is because these color bands is what will help us in translating what is happening with regard to the Omicron variant in the next slide, which is this. So when you look at your bands very carefully, these spots that you're seeing in black, what is in triangle is the number of people in the population who've had 2 infections. That is, this is the second infection that is being detected from the original infection. So these are people who are presenting with a second laboratory confirmed diagnosis of SARS-CoV-2. And that was now as they were moving now into the second wave. You'll find that there was quite a bit of people who had already had an initial infection and were now presenting to healthcare facilities with a second diagnosis of SARS-CoV-2. Now, just look very carefully now as we move into the orange color band, which is now when they were experiencing the third wave. You'll find a lot of squares, a lot of spots, but with squares, and that spills over into November and December of 2020. These are people who, individuals who have actually had 3 infections. That's basically they've had 1 infection, their primary infection, then the second time they had an infection again, and then they're being picked up again with a third, with a confirmed diagnosis of SARS-CoV-2. Now, what does this tell us? When you look at the third wave, it means that there was already quite a bit of population immunity that had already taken place in South Africa. And so you can actually find, because you find like in this third band, I think there are very few individuals who actually who are being found to have primary infection for the first time. Most of the individuals here had actually been reinfected quite a couple of times. And of course, now when you move into January, February, most people, I think, were being reinfected for the third time. So this definitely tells you that there's quite a bit of population immunity that had taken place in South Africa due to the high load of virus that was circulating. The only limitation to this data is that we have no idea whether these people, in addition to being infected, whether there was any history of vaccination. I think that is what did not come out clearly in this data. But of course, so to speak, it tells you that this gives you just a very rough idea about population immunity. And why is this important? It's important because one of the institutions I work very closely with is a department within the University of Oxford. That's the Nuffield Department of Medicine. And one of the questions we've asked ourselves since 2020 is that a lot of us have focused a lot on the B cells, that is your neutralizing antibodies. Of course, it's very clear that neutralizing antibodies tend to decrease from the either from infection or by vaccination. But what we've never really asked ourselves is, because the immune system is quite huge, we've only focused on the B cells, but we've never really focused on what we call the T cells. And the question now we should be asking ourselves is, what is the role of T cells in COVID-19? And this actually tells us why the T cell immunity is much more about, why immunity is really way more about than just focus on antibodies. And this one I'll bring us slowly, for some of us who've forgotten our immunology, I'll just do a quick brush over just to understand what we essentially mean. So what you can see here is our COVID-19 virus, that is the SARS-CoV-2. Of course, when it is detected by the alveolar macrophages that have already been activated by the immune system, they literally just come and they swallow the virus that has been neutralized. That by neutralization, I mean, these are the antibodies, the neutralizing antibodies up here that just come and attach onto the spike protein of the virus. And then the alveolar macrophage recognizes this and quickly takes it in. That is one way in which this is done. The second way in which this is done is where the alveolar macrophages, after being activated, just comes and swallows the entire infected cell that has the virus in. But one of the questions that we ask ourselves is, how does this alveolar macrophage get activated? And the answer is very simple. It is what we call the CD4 T cell. Now, the CD4 T cell activates two components of your immune system. It activates what you call your CD8 T cell, and then this CD8 T cell just goes directly and destroys the infected cell. The other way it does this is by activating the B cell, and then the B cell now produces your neutralizing antibodies, and then your neutralizing antibodies go up here and attach to the virus to inactivate it, and then it is swallowed over by the macrophage. This information is very important because that now drives us to the next slide, which will show you why a high number of CD4 T cells would be important, and not just considering and not just concentrate on the B cells, because that is what a lot of us are doing at the moment. And so we write off a lot of interventions based only on dwindling and neutralizing antibodies, yet we've not focused on the T cell response. And so that brings us now to the vaccine impact against the Omicron variant. And so one of the things that we realize is that vaccination, one of the things that it improves, it actually helps you to induce a good immunological T cell memory. So the information that was published in 2020 was now brought all the way into 2021. And this is the initial data that we are now receiving this is now initial knowledge we are now seeing on how T cells can actually be activated by way of vaccination, even if you have a decline in your neutralizing antibodies. And this is what you can actually see. So up here, you will actually notice that we have very many variants of SARS-CoV-2, of course, starting with the Alpha variant that initially started off in the United Kingdom. And then right now, what we're dealing with is the Omicron variant. So in this study, what actually happened is that since it took place in the United States, is that a certain number of participants who had been vaccinated by either of the 4 approved vaccines in the US, that is the Moderna vaccine, which is the mRNA 1273, it could either be the Pfizer-BioNTech BNT 162b2, it could be the Johnson & Johnson, which is the adenovirus 26 COVID-2S, or the Novavax vaccine. And then these participants were followed up over a period of time. And so the data that I'm presenting here is the 6 months post-vaccination, how their cells look like. So when you look at the B cell, that is the receptor binding domain, the B cells that are produced against the receptor binding domain of the spike protein at 6 months, what you will notice is that averagely, the brown component you are seeing of the bar graph is actually the Omicron, and then the y-axis shows you the B cell responses. You can actually see Omicron behaves quite low. That is at just below 50%, which is just about 42%. But averagely, you will find that for all other variants, these vaccines tend to do fairly well, above 50%. But this is not all doom and gloom, because when you look at now your T cells reactivity at 6 months post-vaccination, when you look at your Omicron, your T cells against Omicron still are quite high. In fact, anywhere just about 85%. And then when you look at all the other variants, your T cell response at 6 months still tends to be very good after vaccination with some of the vaccines that we have in the market. And so you'll find like what we focus on is the CD4, because the CD4 is what activates both your B cells and also activates your CD8 T cells. And you can see your CD4, even after vaccination, even after 6 months post-vaccination, activity against Omicron is extremely high at just about 84%. And so this really drives home the importance of really having populations vaccinated, not only to focus on the B cell response, because the B cell response may decrease, but your CD4 T cell response may still be quite high to be able to enable production of more neutralizing antibodies, so long as you've been, you have some pathogen floating in, either through vaccination or natural infection. But now when you translate this to vaccine efficacy, vaccine effectiveness, because right now Omicron has been with us for just about maybe 3 to 4 months, so we do not have vaccine efficacy data regarding this. So what we have is effectiveness data, and normally effectiveness data tends to be a bit more important because here you're trying to look at how the vaccine is performing in the real world. And so this is a paper that was published just 2 days after Valentine's Day. That was sometime last week, which was trying to look at reinfection rates among patients who've just recovered from COVID-19. And then they looked at two groups of recovered patients. One group had received the vaccination, and then one group had not been vaccinated. And when you look at the results, you'll find that reinfection in the vaccinated patients, maybe just about 2.5 cases per 100,000 persons got infected per day. This is a far cry from the over 5%, I mean, from over the 5-fold increase in the number of cases of patients who had COVID-19 in the past but had not been vaccinated. You find that there's a 5-fold increase in reinfection among patients who are not vaccinated, as opposed to those who get vaccinated. And when you look at now the actual results, when you actually look at the significance, you'll find that vaccination alone among the patients who are 65 years of age and above, you'll find that there's a 60% protection among the elderly who get vaccinated. And you can actually see even the confidence intervals do not cross 1. So it means this is a very significant value of protection. And in fact, this protection is even more marked among the younger people. You'll find there's actually an 82% protection just by vaccination alone. You've not even considered other things. And this also could be driven in addition to other factors by really your long-standing T-cell response. And this is also shown by the Kaplan-Meier curve. In fact, this Kaplan-Meier curve shows this much more clearly. You'll find that there's an increased cumulative risk of reinfection among the unvaccinated population as opposed to the vaccinated population, which is here in blue. This is among patients between 16 to 64 years of age. And then when you look at people who are slightly older, that is 65 years of age and above, the risk also is slightly higher among the unvaccinated population as opposed to the vaccinated population. And then these color bands, when you see them not crossing each other, like here, because here they are not crossing, here they're not crossing, it means that this cumulative risk is quite significant in terms of reinfection. And then lastly, what I would also want to mention is patients normally ask me, is it really important to get your booster shot? Because only the 2 doses for them seems to be quite adequate against protection. And so this is some work that was published by the CDC early this year, trying to show why a 3rd dose of vaccine may be quite important for people who've already received 2 doses of the original primary vaccination series. And this one will concentrate more on the mRNA vaccines, because that is one of the vaccines that is mostly being used in the US, and luckily even in Kenya we have a bit of those mRNA vaccines floating around. So this paper basically tries to look at the number of people as opposed to the 2 vaccinations versus those who are unvaccinated versus those who received 3 doses, how many actually present to emergency departments, actually how many of those present to hospital. And this is data that was being looked at between August of last year to just about last month, that is January. And you'll see that in a very brief way, is that the people who are unvaccinated, the number of people who presented to hospital, 47% were unvaccinated. And that is as opposed to only 19% who had received 2 doses within 6 months of their first dose. And then, of course, when you compare the unvaccinated versus those who received their 2 doses, but received 1 dose maybe in January, then received the next dose maybe in July, you'll find that 26%. So it's still quite low. The number of the percentage of people presenting to hospital is much lower than those in the unvaccinated, but slightly higher than those who received their 2 doses within the 6 months. And so that is why it is important that in most of the schedules that we are seeing, most of the vaccine doses are really being concentrated in between 6 months. So you receive your first dose maybe today, and then your next dose may be on day 28 or 3 months after your first dose. So you really want to concentrate your dosing regimen among this population, among this range, so that you really ensure that your vaccine efficacy remains quite high and you reduce the number of people going to hospital. But the story gets even more interesting when you receive your 2 doses plus a booster. Very few people, just over 8%, just slightly over 8% present to the emergency department, as opposed to the 19% who've received only 2 doses. And that cuts across both Delta and Omicron. When you look at Omicron, because right now Delta still occupies quite a huge chunk of what is circulating in the United States, and Omicron is slowly catching up. When you look at Omicron, as opposed to the unvaccinated, 39%, those who received 2 doses of vaccine, only 10%, as opposed to 39% presented to emergency departments. When you look at now the Omicron variant, now Omicron is still something that is evolving. So you'll find that still quite a bit of a huge percentage of patients were still presenting to hospital, even after having received 3 doses of vaccine for protection against Omicron. So I would want to concentrate a bit more on this Omicron to see what exactly is driving up these high numbers. And so when you look at the next slide, we'll look at you can quickly look at the age between 65 to 74 years upwards, up to patients of 85 years and above. And you'll find that the percentage of Omicron, even after receiving 3 doses, seems to be extremely high. The number of patients who, after receiving 3 doses, still end up in hospital due to Omicron. So one of the questions that we ask ourselves is, do we need to concentrate additional booster dosing among this population of people 65 years and above? Because when you look at people between 18 to 64 years, the numbers are still quite low. So moving forward, you may not concentrate a lot of your booster dosing among this population, but you probably may need to concentrate a bit more on this population. Like after your 3 doses, how many additional doses would you want to receive post your 3 doses? So those are the important questions that I think we need to ask as we move along. But generally speaking, when you look at the unvaccinated versus the vaccinated, you'll find that there's a substantial decrease in the number of people presenting to hospital, even after receiving the 2 doses of vaccine, whether they've spaced it in between the 6 months or beyond the 6 months. So that really reinforces the importance of vaccination against Omicron. Now, when you look at the vaccine effectiveness, when you look at specifically Omicron predominance, you'll find that, and then you do your reference against patients who've not been vaccinated, you'll find that from 48.6% of people who actually present with a positive result for COVID-19, you'll find that for those who receive 2 doses, either between 6 months or beyond 6 months, you'll find that our vaccines don't do very well against the Omicron variant. But you'll find that when you give a booster dosing, in addition to the 2 doses of your vaccine, when you give a booster dose, your vaccine efficacy substantially increases to just about 82%. And that one is even better when you're dealing with the Delta variant, because the Delta variant is what has been responsible for a lot of the hospitalizations that we've been seeing. And then lastly is to really look at the hospitalizations, because when you look at the hospitalizations, the number of hospitalizations taking place, you'll find that to those people, as opposed to those people who've not been vaccinated, the moment you receive 2 doses of your vaccine in between within your 6 months, your vaccine efficacy tends to be quite good at just about 90%. And even if you space it out a bit more, still retain quite a good amount of efficacy. But that is a bit problematic when you look at Omicron, because with Omicron, you'll find that if you only receive 2 doses of vaccine, you'll still find that you have quite a bit of people presenting to hospital, even with your 2 doses. But the moment you increase to 3 doses, your vaccine efficacy substantially increases. So this was just something to help the audience think about, and I would love to really hear what people think. But I think for me, some of the questions that we may need to ask ourselves, or I mean, some of the questions we need to answer as we move along, as I conclude, is that number one, first of all, vaccines are highly encouraged, not only just to look at neutralizing antibody decline over time, but it is really to also try and maintain your T-cell response, so that your T-cell response can encourage production of additional neutralizing antibodies in case you are hit or reinfected with another variant, because that is what now makes your infection much more milder. But it does not mean that the infection, the variant itself is mild. So I think that is something that we need to take home from this presentation. The second thing is that we need to understand is that booster dosing is highly encouraged, of course, but one of the questions that even as a study team, what we're asking ourselves over time is what would need to be the frequency. And this frequency most likely would need to focus it a lot more on the elderly, because the elderly may probably require a bit more booster dosing as we move along, because as you may realize, a lot of immune aging takes place in the elderly, so their T-cell response may not be as profound as the younger population. So for them, they probably need a bit more stimulation of their T-cell responses, and that may be achieved by repeated vaccinations over time. And then memory T-cells definitely will play an important role as a second line of defense, though that is something that we're still studying as we move along. And then one of the things that manufacturing companies are trying to do is to manufacture variant-specific vaccines. Personally, and I think with other colleagues, we find this questionable because normally from immunology, normally T cells tend to cross-protect. So if it protects you against one wild-type virus, chances are high it will also protect you against other variants as they come along. So personally, from the science, we don't think it is feasible to keep producing vaccines for specific variants. But of course, these are something that we need to look at as we do more studies on T-cell evolution among individuals who've been vaccinated. And with that, I would love to take any questions. Thank you very much.
Thank you very much, Dr. Yaunga, for a very insightful, concise, precise, and brief presentation. It's rare to find someone presenting a talk on public health, molecular biology, virology, immunology, and also public speaking in such a short period of time, but you managed to deliver. And personally, I've learned quite a bit. So I think the second thing is you've highlighted the very important role of the T-cell response. I think a lot of people have really focused on the antibody response and whether it's present or not. But today you've shed a lot more light on the T-cell response and just how important it has been in terms of reducing the severity of illness and the numbers of people who are visiting outpatient departments and inpatient departments, and not just in Kenya, but across the world. So thank you very much for sharing. I think at this point, I shall look at the chat and just see if there are any questions. So the first question I can see is from Ben Olo. Thank you, Ben, for joining us. And he asks, with the continued vaccine uptake in the country, would you say that what the worst of the pandemic has passed, and your recommendations on the use of face masks at this present moment?
That's a very good question. In terms of whether we are past the worst of the pandemic, I think looking by the trends of how the virus has behaved and looking at our test positivity rates across, despite our very, I must say, we still have a very low vaccination rate taking place. But because of that, you still find that we still tend to register very low numbers of patients presenting with COVID-19, particularly those who are presenting to hospital with severe COVID-19. I know, like right now, I think in my unit, I should be having maybe only 2 or 3 patients, actually just about 3 patients in intensive care unit. This was unlike last year, August, May, where I had over 50 patients, about 20 in intensive care and 30 in HDU being managed for severe COVID-19. So looking at just the hospitalization, I think we're already past that problematic stage. Now, in terms of whether in terms of infectivity over time, I think one of the things that we need to realize is that even despite our low vaccination rates, we still tend to have very low numbers. So that begs the question, and that is why I really wanted the audience to focus on what the data that was coming from South Africa, because South Africa, you see, like their third wave started and almost diminished very quickly. And partly the reason is because they seem to have very high population immunity against the virus. Whether it is by vaccination or not, we are not sure, because also South Africa, their numbers are slightly better than us, whereby I think just about 56% have received at least 2 doses of either vaccine, whether it is Pfizer-BioNTech or the one shot of Johnson & Johnson. So they are not fully, I mean, just a very low number have been fully vaccinated, but you find that their numbers are so low, and you can actually see that from the third wave, there's so much population immunity. Now for Kenya, unfortunately, we don't have that data, but my suspicion would be that could be the case as well, like what is happening in South Africa, because their restrictions were quite high, but our restrictions here were not as massive, but you still find that people are mingling quite a bit. And so my suspicion would be there was quite a bit of population immunity that was acquired during that process. And so it is just being augmented by vaccinating populations. Now, where that point becomes very important is that we should not tell ourselves that because we don't have the numbers. And so based on that, and based also on the reduction in the neutralizing antibody levels that we have, and also because of the elderly populations that we have, I think it is important to keep sustaining production of, I mean, just maintaining the integrity of your immune system. And unfortunately, right now, the only way you can do that, or fortunately, the only way you can do that is by making sure that as many people as possible really do get vaccinated, so that we can achieve some of those objectives. When it comes to the issue of face masks, unless you know your level of population immunity, it will not be very prudent to eliminate some of those non-pharmacologic interventions. And that is why a lot of bodies insist that if you have at least 60% of your population immunized, and that could either be by vaccination or by natural infection, then you can comfortably start minimizing some of your non-pharmacologic interventions. I don't know how far Kenya has in terms of estimating some of those numbers, but I think if you hit just about 60% or above in terms of population immunity, it would be good to start reducing on some of your non-pharmacologic interventions. I don't know if I've answered the question fully.
Thank you, Doc, for that response. There's another question: any evidence of antibody-dependent enhancement?
Yes, that's a good question. So part of the reason why some of the vaccines were stopped in other countries, especially among the younger population. And here we are talking about the viral vector vaccines, Johnson & Johnson, as well as AstraZeneca. Partly part of the reasoning is because it could be due to the problem of antibody-dependent enhancement amongst, but that is really amongst the younger population. I am yet to see a case report of antibody-dependent enhancement among the elderly, because remember, the elderly, in a lot of countries, that is where now the viral vector vaccines were shifted to, and then the younger people were prioritized for the mRNA vaccines because of that same story of antibody-dependent enhancement. So there have been a few bits and pieces and a bit of postulation that could have been happened secondary to vaccination with your viral vector vaccines in the younger population. But among the elderly, we are yet to see that, and there's been no comprehensive case series documenting some of these cases, so to speak.
Thank you. Walter asks, when do you anticipate the transition of the pandemic to becoming an endemic, in our area? When do you anticipate that COVID become just endemic and be accepted as such?
Yeah, so I think here I'm mostly using some of the curves that we are looking at from the Johns Hopkins website. In fact, in a lot of countries, we are not really at pandemic level. They're actually at endemic level. Like when you look at countries like Australia, almost 90 to 95% of their population has been vaccinated. So already that risk has been eliminated of it being a pandemic. In the United States, unfortunately, they have all the resources, but there's also been a bit of a problem with the issue of vaccine hesitancy and anti-vaxxers. And so they've not been able to achieve the vaccination rates that they've been able to achieve. And so you find that, unfortunately, if you reduce your percentages in isolated countries, but in other countries you have very poor vaccination rates, then at that point in time, you still cannot declare a pandemic to have been finished until a certain percentage of your population has at least derived some form of immunity. And so here we are talking about the prescribed WHO percentage of 60%. So right now, I think the most ethical way to achieve that kind of immunity is by vaccination. And so that's why you see that the surrogate that is being used for measuring this immunity is how much of your population has received at least the 2 doses of the primary vaccination series. Now that is now what is used to actually define whether that country can now start living with the virus. Because right now, I think, as opposed to 2020, I think now we have drugs in the market, at least in terms of managing severe disease and moderate disease. We are still yet to get access to the oral medications, as well as the very expensive monoclonal antibodies to treat patients who have mild to moderate disease, but at increased progression, who have a risk of progression to severe disease. But the truth of the matter is, for it to be declared maybe that you can actually live with the virus, you need at least 60% of the population vaccinated, and it should be across the entire spectrum of the globe, not in isolated countries. But isolated countries, according to the international health regulations, have their right of degrading their status in terms of disease spread from pandemicity to either endemicity and the like.
Thank you. That was quite detailed. I think the Kenyan numbers is that now are still at about 13% for people who've received 2 doses. So we are still a very long way from that 60%. And I think the same issues, hesitancy, skepticism of effectiveness, and laxity, as people think the pandemic has fallen off. But I think the key message from this talk is the vaccine have been seen to be working even against the Omicron, and we must keep emphasizing this. There's another question on the potential utility of co-administration of vaccines such as influenza, pneumococcal RSV with the COVID-19 going forward.
That's an excellent question. In fact, I think one of the things that we are now starting to move away from is this business of isolating COVID-19 and managing it in silos. In fact, for all my patients right now, especially those who've recovered from COVID-19, in addition to getting the COVID-19 vaccination, we also prioritize them for all the other vaccines. So for example, if you're 65 years of age and above, we definitely will get you in for the pneumococcal vaccine. And to start with, we'll just do the PCV13 because unfortunately, that is the pneumococcal conjugate vaccine 13, because unfortunately, we do not have the pneumococcal polysaccharide vaccine 23 in the country. So, but at least giving them the conjugate vaccine is better than giving them absolutely nothing. So that is the first question. So I mean, that is the first thing. So for patients who are 65 years of age and above, patients who are 50 years and above, who have other comorbidities like diabetes, hypertension, patients who are 18 years and above, but with a known history of smoking or chronic obstructive pulmonary disease, the moment you pick them up in the clinic from a diagnosis of COVID-19 in hospital, please prioritize them for all the other vaccinations. Make sure that they are started on their course of the pneumococcal conjugate vaccine 13, get them up to date on their, make sure that they are annually vaccinated against influenza. For those ones who, for some of the patients who presented to hospital, some of them had altered, had renal disease that was picked up either because of their comorbidities and such. Make sure that they're also covered against their hepatitis B, they're covered against hepatitis B. Screen them for their immunity against hepatitis A. If they're not immune, vaccinate them against hepatitis A. Really cover your bases very comprehensively among these patients, and don't only just focus on COVID-19. And I think that's a very important point that has been raised, that don't just focus on COVID-19. Look at all the other respiratory pathogens, as well as any other vaccine preventable disease that you can address in that one sitting, so that the patient is very well informed that other infections can actually kill them, not just COVID-19.
Thank you, Dr. Yonga, for really highlighting the important role of adult vaccination. I think for us, we've always just really focused on KEPI vaccines for children, but COVID and now what we're seeing more and more with some of these respiratory infections highlight the important role of adult vaccines for the elderly, for the
So sorry, Dr. Leon, I don't think I can hear you quite well. Unless
elucidating on that, someone has posted on the chat, see confirmation. Can you hear me now?
Yes, I can. Yes, I can.
Okay, great. Yeah, there's a case, someone says a person presents with a good number of signs and symptoms of COVID-19, refuses to visit the lab or the facility and insists on medication from your premises. What is the best thing to do? I think that's more of an ethical challenge and a virological one, but please feel free to assist.
Yeah. So I'm just imagining which facilities this they're presenting to, because I think that's the last part of the question, if I've heard correctly, that they again present to a facility.
No, he refuses to visit the facility. I think he wants to be managed from home and doesn't want to do a confirmatory COVID test.
Does not want to do a yeah, that's a difficult one. That's a difficult one because unfortunately you also cannot force someone to go to a health facility if they do not want to. It could be because of their own liking, or it could be because of cost or anything. But ideally, I think that my best option would just be to encourage that, or to really try and reassure that patient that it is in their best interest to be seen at least, or to exactly know what we are dealing with, because unfortunately you cannot treat patients blindly. You need to have an idea of what exactly you're dealing with. Because for that patient now, unfortunately, I would not even know what we're dealing with, because as you may know, COVID-19 has very many mimics in the community, extremely many mimics. I know of patients who've presented with signs and symptoms of COVID-19. I know a colleague in Kisumu was telling me the same, but on testing, the patient was found to have malaria. So sometimes it's very good to screen for some of these things and have some form of confirmatory diagnosis. Otherwise, you end up, for lack of a better word, misadvising and mismanaging the patient. So they really need to be reassured and encouraged to present to a healthcare facility, because that is where now more targeted interventions can take place.
Thank you. I hope the person who raised the question has been answered. So I think we'll have one last question. And Walter, who has been very active today, asks, when would you recommend the booster dose? How long after the second COVID dose would you recommend one to get a booster?
Yeah, that's another nice one. So when you look at your immunity levels, averagely speaking, by just about 6 months, you start fading off on your neutralizing antibodies. That is averagely. When you look at the elderly, I just didn't present that because of time, but when you look at the elderly, they tend to shed off their neutralizing antibodies much faster, actually anywhere between 4 to 6 months. And so the elderly is a bit more of a particular situation, because, for the elderly, in addition to their decline in their neutralizing antibodies, they also seem to have aged quite a bit in their immune system generally. So even their T-cell responses may be a bit problematic. So for the elderly, I'd probably boost them much earlier, maybe just after 4 months. And then for the rest of the population, I'd probably look at just about 6 months. But now after the 6 months, I think what we're still not sure about is whether we are supposed to boost frequently. But my hunch is for the elderly, they may be a bit more frequent boosting, but that period is still what we don't know. But for the initial boosting, that is the third dose, most likely for the elderly, I'll target them at 4 months, but also that is subject to availability of the vaccines. I think in the Kenyan policy, I think it's 6 months, if I'm not wrong, for boosting, especially for these high-risk populations or for people who may interact with the virus a bit more, and they're being boosted at 6 months. But for people whose immune system may be a bit of a problem, I'll probably boost them much earlier, from 4 months thereabout. But now, subsequent boosting is still something we're still looking into.
Thank you very much for an excellent presentation. We really appreciate you and all the information you've been able to share with us today. I will ask Walter comments, yes, the policy is 6 months across the board, but I think you've said 4 months for those, especially the elderly or severely immunocompromised. I think I'll ask Dr. Kigondu to say a word to us before we close the webinar, and to thank you on behalf of KMA.
Asante.
Thank you very much, Leon. Thank you very much, Dr. Yonga. I want to recognize the presence of the Vice President of Kenya Medical Association, Dr. Amos Otara. I want to thank you for a very good presentation, and I think we are continuing to learn with the new diseases. These trainings have shown that learning is continuous, as Dr. Paul Yonga would acknowledge the need for continued research and continued learning. And we at the Kenya Medical Association are very pleased to be hosting these clinical webinars so that we can continue engaging the health professionals and the public on this. So every Thursday at 2 to 3 o'clock, come learn something new. Also every Tuesday between 7 and 8:30 is the psychological and mental health being webinars that have proven to be very useful in this series. So we at the Kenya Medical Association want to thank all of you for participating, and these presentations will be available at the Kenya Medical Association YouTube page. You can share with those who have missed, so because learning is continuous. With that, I want to thank all of you and wish you a happy afternoon. And thank you very much, Leon, for your moderation. Bye for now.
Thank you. Goodbye.